Hello, and welcome to the Diabetes and the Asian American Pacific Islander Community webinar. My name is Louise Gonzalez, co-chair of Atlantic Health Systems Asian Pacific Islander Business Resource Group. One of our goals is to educate local communities on health, wellness, and social issues. We have chosen diabetes as our main health topic due to its profound impact on our communities. We are excited to partner with Atlantic Health Systems Community Health Department, our well-being team, as well as our featured speaker, Dr. Ronak Patel. Dr. Patel is board certified in endocrinology, diabetes, and metabolism through the American Board of Internal Medicine. He completed his internship, residency, and fellowship at Mount Sinai Beth Israel Medical Center. Currently, he practices at the Diabetes and Endocrine Institute located on South Street in Morristown. Dr. Patel will be speaking about the effects of diabetes on the Asian Pacific Islander community. Following that, we will continue with a presentation for Atlantic Health team members on the benefits of participating in our internal diabetes program led by Kathy Robb. With that, I am proud to introduce our first speaker, Dr. Ronak Patel. Dr. Patel? Oh, Dr. Patel, you're on mute.
Sorry. Thanks, Liz, for introducing me, and thanks to Jessica for inviting me. I think it's a very interesting and important topic which you have selected for me to talk about because, as you said, it impacts our communities a lot, and it's something which is not always an area of focus on a lot of talks we have. So again, morning to all, and thanks for showing up today. So without any delay, I'm going to start with the talk. So I don't have any disclosures for this particular talk. So the reason it's important to talk about diabetes in whole is because it's an epidemic, as we all know. Every 17 seconds, someone is diagnosed with diabetes. So essentially, by the time I finish my talk, there'll be approximately 50 people who will be diagnosed with diabetes. So just think about it. It's mind-boggling the amount of diabetes and pre-diabetes we see in our not just in our communities but overall as a population. 26 million children and adults in the United States live with diabetes, and there are approximately another 80 million who have pre-diabetes, who are, if they don't do the right stuff right now, they are just waiting to get diabetes, and obviously the complications which follow. And if we don't make a meaningful change with our lifestyle, with the policies we have, with nutrition, diet, exercise, and healthy living, then we are just waiting for 1 in 3 adult Americans, or 1/3 of the adult population, to have diabetes by 2050. So this is a lot, affects a lot of lives, a lot of families, a lot of communities. It's just crazy the amount of diabetes and pre-diabetes we have and we expect to have in the future if we don't make a change right now. Now, it's important for the policymakers to know as well, because it's not just the doctors and the patients, it's also the dollar figure to it, or the dollar amount to it. So if you see the amount of cost, direct and both indirect cost of diabetes in America has increased rather significantly, almost doubled in the 10 years between 2007 to 2017. Again, it's even higher probably right now, and if you look at, it's $327 billion, and that's essentially gross domestic product, or GDP, is greater than GDP of more than 150 countries as a whole. So just the diabetes piece is so expensive for the country. So I think another reason for the policymakers and for communities to make a change, because if it's not for health, it's also for the dollar amount linked to it. Now, when we talk about the Asian American, Native Hawaiian, and the Pacific Islander communities, I think sometimes people don't understand it's not just 2 or 3 cultures or communities we are talking about. It's a bunch of them, right? So sometimes, and even this is also true for healthcare providers and people who work in healthcare. They do not understand that it's not just 1 or 2 people from 1 or 2 countries, or who make up this bulk of it. It's the list is right there. I'm sure. I don't know who the participants are right now. I can't see their names, but I'm assuming that it will be falling in one of these cultural community categories. And it's important to understand that, because even within these communities, especially within the Asian communities, the impact of diabetes is not the same, it's different. So you have to look at everyone individually and customize plan based on them when it comes to screening, when it comes to diet, exercise, and the rest, and obviously the medications at the end. So as we have been talking all throughout, it's an epidemic in the Asian American, Native Hawaiian, and Pacific Islander communities. And 8.4% of Asian Americans have diagnosed diabetes. Now, this is diagnosed. There is a lot of undiagnosed diabetes as well. And the real number is probably much higher. But even with the diagnosis, it's still almost close to 10%. And Asian Americans have 30% more likely to have type 2 diabetes than non-Hispanic white counterparts, even if they have a lower BMI. And we'll talk about how BMI can be sometimes misleading, and what uh, people need to look at when it comes to BMI as far as the number is concerned, and why that happens. The other impact of diabetes in Asian American communities is during pregnancy, where Asian American women are much more have likelihood of getting gestational diabetes, which not only impacts the pregnancy but also impacts the baby. So it's important that they are screened in a much more aggressive fashion, even before pregnancy, and obviously during pregnancy, because of a high risk of them developing diabetes. And also after pregnancy, because once you have gestational diabetes, you're certainly at a higher risk of developing diabetes over the next 5-6 years or so. So it's important that not just the patients, but also the physicians and the healthcare team taking care of that particular patient is aware of this. When it comes to the Native Hawaiian and Pacific Islander community, around 50% of Samoans, there was a study which showed around approximately 50% of Samoans, both men and women, in an adult age group, which is 25 to 64, had type 2 diabetes. And this number could be much higher even right now. Even if it's not higher, just imagine 50%. So every other person, an adult, a functional person who's in the productive part of their life having diabetes, it takes away so much from the productivity. At the same time, obviously, the disease burden which they carry and the complications which follow it. And even when they get diabetes, they have high risk of complications and death rates, which is around 20 to 22% greater than a US population. So it's not just getting more diabetes, it's also the high risk of death. So it's important that the screening is on top. You catch diabetes early, you make meaningful changes to prevent complications, and obviously the worst, which is a fatal outcome, especially at a young age. Now, why is it important to focus on these communities we are talking about today? It's because they have a much higher prevalence of diabetes, and an average white person would have anywhere from 7 to 8% risk of developing diabetes, or I would say 7 to 8% of the total diabetes population would have diabetes, compared to Asians or a Filipino. And even in Asians, you can see the diabetes prevalence is not equal. Like you would see in Filipino and South Asians, the prevalence of diabetes is much higher than a Japanese or a Korean population. So obviously it's still higher. Overall, the diabetes prevalence in Asian community is higher, but even within Asians, there are subgroups which have even higher prevalence. And obviously the Pacific Islander population has a much higher prevalence of diabetes to begin with. This was a nice data which came out from a rather significant population study from Kaiser Permanente in North California in 2010. And there's a lot of data which comes out from California as well for these populations studies, and it's pretty mind-boggling to see this. Now, since we know that diabetes impacts communities as a whole, more likelihood of having diabetes and pre-diabetes, it's important that we start screening sooner. And so what are the criteria for screening? So any adult who is overweight or obese with one risk factor should be screened. If you ask me personally, every adult should be screened for diabetes, period. But if you go by the guidelines, they will say any adult who is overweight or obese and has one or more risk factors, they should be screened for it. Now, if you look at the BMI, you see the BMI cutoffs are different, right? So the BMI cutoffs for all the population, for most of the population is 25, but especially for Asian Americans, the BMI cutoff is 23 because we are a different phenotype. We are genetically different. And so the BMI cutoffs are different. You don't have to be that big as an Asian to get diabetes or pre-diabetes. So it's important that the BMI cutoffs are kept in mind and everyone is not just lumped together as a homogeneous mix, because it's not true. And when it comes to risk factors, it's pretty straightforward. Anyone in family with diabetes, high risk. So we are already talking about, today's talk is about high risk race. So if you have an Asian American with a BMI of 24, should be screened because the race itself is a risk factor. At the same time, the BMI is more than 23. History of the other risk factor is history of heart disease, hypertension, cholesterol issues, women with PCOS, if they are physically inactive for whatever reason, and obviously if they have signs of insulin resistance like acanthosis nigricans. Uh, if you have pre-diabetes, then the testing should be done at least on an annual basis, if possible every 6 months. But if that's not possible, then at least once a year would be reasonable. Women who have gestational diabetes should have a lifelong testing at least every 3 years, because there is around 30 to 50% chance that they will have diabetes in the 5 years after diagnosis of gestational diabetes. So they should be screened every 3 years. And all the patients that for all other patients, the testing should begin at 35. Now, this is a change. It used to be 45, but 2000 this year, actually, the standards of Medicare in diabetes was published by ADA, and they changed the screening limit from age 45 to 35. So because they understand, let's start screening early, let's start screening sooner, because we're missing a decade of that patient population where we're not screening them, and by the time you see them at 45, they already have diabetes. So they have lowered the age so more people can be screened and more pre-diabetes and diabetes can be caught early, and more meaningful change to avoid complications in future. Now, if the testing, if your A1C or fasting glucose or glucose tolerance, depending on how the testing was done, is normal, then at least minimum every 3 years, minimum. So if you get an annual screen, that's fine, but at least every 3 years, you want the testing to be done to make sure you're not developing anything. And obviously, people with HIV should be screened on regular basis as well. Now, we talk about the BMI cutoff here, where we talked about a BMI of Asian American is 23. Now, you can phenotypically look at these two folks. One clearly a white, and the other one is an Asian American. And you can see they have both similar BMI, but the body fat is much higher in an Asian person than a non-Asian. So, and that is the reason you cannot just go by phenotype, what presents in front of your eyes, because there is something deeper which is being missed, which is a higher fat content. So it's important that the BMI is lowered. The threshold for BMI is lowered in Asian Americans to catch pre-diabetes and diabetes much sooner. There is a big campaign going on. There's a website which is screenat23.org, which essentially talks about why it's important to screen at a BMI of 23. Because if you start doing that, you'll have around 200,000 Asian Americans with diabetes who are not diagnosed right now, will be diagnosed, and around double the amount of that, around 400,000 of patients with pre-diabetes who have not been diagnosed will be diagnosed. So it's essentially, there could be, if you don't screen it, you could have more than 500,000 of people with diabetes and pre-diabetes and all who are not diagnosed, because if you're just going by a BMI of 25, you're not going to screen them, because that's not the guideline. So it's important. And this is true not just for, as I said, I might have said this earlier, for patients, but also for healthcare providers to understand that the BMI cutoffs are different for Asians. Now, how would you how to screen And then second, what needs to be done. And we'll talk about the diet and exercise piece and the medications at the tail end of the talk. So when it comes to screening for patients with diabetes or pre-diabetes, we have essentially three main options. One is fasting plasma glucose and hemoglobin A1C, or a 2-hour 75-gram glucose challenge. Most people will be screened by an A1C because it's a straightforward test. It's very reliable in almost everyone. There are few caveats in which A1C is not reliable, but that's far and few. And but in most people, an A1C is a very good reliable marker when it comes to screening. So if your A1C is less than 5.7, it's normal. If it's between 5.7 to 6.4, then it's consistent with pre-diabetes. And obviously, if it's more than 6.5, it's consistent with diabetes. When you look at the fasting plasma glucose, if it's between 100 to 125, it's consistent with pre-diabetes. If it's 126 or more, it's consistent with diabetes. And then 2-hour glucose challenge, where 75 grams of glucose is given, and then you measure the glucose at 2 hours. If your blood sugar is between 140 to 199, then that is consistent with pre-diabetes. And if it's more than 200, then it's consistent with diabetes. Now, this testing is for non-pregnant because the cutoffs for glucose tolerance is different for pregnant population, and that's beyond the scope of this talk. So we're not going to talk about it, because it's a very different way to screen and manage as well. Now, if you have diabetes, and if you have pre-diabetes, then it's important. It's kind of a wake-up call that your body is shouting out that something needs to be done, and you're still in a very good place where you can potentially reverse this process by making lifestyle changes with healthy diet, exercising, in certain patients, medications. Weight loss ends up being the mainstay of treatment for most people. Again, the BMI might be 24 or 25, so so the patient or their families might think that they're not that big. And yes, phenotypically they're not big, but they still have more fat storage in them, or fat reserve, compared to someone else, which increases risk of insulin resistance and then diabetes. So yes, weight loss is important. So if your BMI is 25, which is essentially not that bad, but yes, there's another 2 points to go down on BMI. So getting a little skinnier or losing the fat weight, you can build muscle mass, that's fine, but losing fat weight is important. Now, there will be certain patients in which cholesterol medication might be recommended based on the risk factors. Same thing with aspirin. Aspirin is not something which should be started straight away without discussion with the doctor, because there is increased risk of bleeding. It's important that you just don't pop an over-the-counter aspirin because you have pre-diabetes. You want to cut down on the risk. You always want to have a discussion with your doctor if that's the right thing for you. If you're smoking, then obviously smoking cessation, cannot stress that enough. It's the single most important thing you can do, not just for heart disease, but your overall health, and not to mention cutting down on the cancer risk. And there are various programs locally and nationally which you can enroll when it comes to making those lifestyle changes. And as I said, in certain group, you could consider metformin to help reverse diabetes, but that's usually not the first day for patients. And obviously, if you have diabetes, then lifestyle changes, as I mentioned, stays. And then if that's not enough, or the diabetes is severe enough where it needs something on top of it, then the medication regimen can be started. So I like this quote. Let food be thy medicine, and let medicine be thy food. And I strongly believe in it, and I strongly recommend that to my patients as well, because it's all in what we eat. It's all how we burn out. Yes, there is genetic predisposition to diabetes. Someone could be more likely to get diabetes than other population, despite of them doing everything right. But even if that's true, it will cut down the risk of complications and severity of diabetes, or the number of medications you need to take. So there is no shortcut to diabetes control or good health, and you have to be careful with what you eat. Now, there are various studies and various data which have come out over the last 40 or 50 years. And if you look at everything, it all boils down to eating plant-based diet. You can have Mediterranean food, which is a lot of whole grain vegetables, legumes, fruits, nuts, seeds as a foundation. Olive oil is a very healthy source of fat. And if you want to add meat to it, then white meat or fish or seafood is a much better alternative than having the red meat. But bulk of your nutrition should be coming from plant-based or plant-focused food plan. Cutting down on carbohydrate. Now, when I say cutting down on carbohydrate, I'm not talking about zero carb diet, because I highly recommend against it. And the reason carbs are healthy, you need carbs to survive. Our brain works on carbs. It doesn't work on fat and protein. So we need carbs. And unfortunately, carbs have received a bad name. But obviously, if you're eating more carbs than you're burning out, or if you're getting unhealthy carbs like from junk food and stuff, then obviously you want to cut down on that. But carbs are important, and you want to eat healthy carbs. Uh, Cut down on sugar and salt intake, very important. I think an average American eats way more, twice or three times more salt and sugar than what we need. So that needs to be cut down. And the best part of trying to control your pre-diabetes and diabetes with food is it has no side effects. People are always concerned about side effects, and this has no side effects. So go on with it. Exercise, again, very important. We talk about it all the time. But then unfortunately, it takes a backseat. But we cannot afford to do that. Our bodies are designed to move. We need to move, right? We as a creature, just like other creatures which are still moving, we have decided to go for a lifestyle which does not allow us to move. So we have to find a time for us to have some kind of activity going on. We dedicate that half an hour, at least 4 to 5 days a week, where we are just doing some kind of exercise. When we don't move, that's when you have obesity, heart disease, stroke, cancer risk happening. And cardio is important. You can add strength training to it. Just walking 30 to 45 minutes a day, 5 days a week. That's it. Nothing fancy is required. Keep it simple. Do something which you can continue for a long time, which you can stick to it. This is not about just doing something for a month or 6 months for a year. You're planning, you're making a lifestyle change for rest of your life. So it's important that you pick something which might not sound that cool. It might not be what other folks are doing around you, going to the gym and exercising and stuff. It's all about what you can do in a long run, day after day, which is going to eventually matter. It's not about a short outcome. And don't expect miracles. I started exercising for 1 week or 1 month. I've not lost weight. Nothing has changed. It's not gonna be a miracle. It's gonna take time. It's gonna take probably 4, 5, 6 months for you to start noticing some benefit. But then once you do it, those benefits will continue, and it will motivate you more to go for it, to achieve it. So make sure you stick with the plan and have patience in it, and you will see the returns at the end. And again, no side effects, and it'll make you feel much better once you finish your exercise routine. Sleep, very important. Highly underrated. People, we have this work schedules have changed because of the type of work we do now. There are people who work night shifts, very difficult for them to have a good sleep. And sleep is not something just about the amount of hours you sleep. It's also when do you sleep. So it's important that you go to sleep at a good time, say 9, 10, and then you're up by 6. You can't fool your body by saying that I still sleep 8 hours a day, but it's or 7 hours a day, but it's during the day because at night I'm working. That's not the way our body was designed. We have a circadian rhythm. We are not a nocturnal creatures. So it's important that we have a good sleep hygiene, and we do everything to improve on it. And stress reduction, I don't think I need to say anything. Everyone knows about it. So there are essentially 4 cornerstones to good health and for pre-diabetes and diabetes prevention and treatment, and along with the other things. But the 4 main things are healthy diet, exercise, proper sleep, and stress reduction. And it's not an option that if you nail 2 out of 4, then you're fine. It's all 4 need to be achieved for you to have a good health. And obviously you're going to feel much better if you keep doing it on a regular basis as well. Now, briefly talking about the medications, the good thing is we also have more medications now than what we had before when it comes to helping people with diabetes and with weight loss. Now, metformin is a classic medication. It's a very old but very safe, very well used and studied medication, which has shown significant benefit in certain pre-diabetes population where we prescribe. Oops, and with patients with diabetes. And then we add medications on top of it based on the risk factors, something like Trulicity or Ozempic, which helps with weight loss. It has some cardiac and renal protection. If I have someone with heart failure, then we will think about medications like Jardiance or Farxiga. So the good thing is we have choices now, and we can select a medication based on an individual. So it's important that you discuss with your primary care physician or with your endocrinologist to see which would be the right medication for you. I see patients who are still on metformin and sulfonylurea for the last 20, 30 years, and their A1C might not be that bad, but we have better things now out, very well studied, and which have shown to have significant benefit with cardiac and renal protection. So something to talk to your doctor about as well at your next appointment, that can we do something different? Can we change things around, which can help me? And I again strongly believe in this. I do prescribe documentaries to my patients. I really like it when I do that rather than I prescribe medications, because I know I'm giving them, I'm making them in charge of their health, and not just making a meaningful difference for the next year or two, but for a long run, where they're making a lifestyle change, and hopefully they will see that benefit and they will spread it among their communities, and it will be like a good chain reaction going on, where our communities will get healthy. Something for all of you, if you've not seen it, I highly recommend that maybe over the weekend or the next couple of weekends, you watch it along with your family, because um, it could be life changing for a lot of people to see how so far the guidelines on health, diet and stuff have been made, and to an extent people were misled, and why it's important to eat healthy, to eat more plant-based, to see exercise and see the real life benefits of doing so. And at the end, you want to eat well, move well, stress less, and just be happy, love more people around you, and make earth a better place for all of us. So thanks to all for patiently listening, and I think if you have any questions, I'll start taking them now.
Yes, thank you so much, Dr. Patel, for providing your insight on diabetes within our community. Definitely a lot of eye-opening statistics and great resource that you shared. As Dr. Patel said, we are opening up questions. If you have any questions, please put them into the Q&A chat below. We'll wait a few minutes just to see if any questions do pop up. Perfect. So we have our first question, Dr. Patel. Are there any specific suggestions to helping people change their diets?
So the specific suggestions can be given when you evaluate an individual in a particular setting. But my general recommendation is just what I showed, that plant-based diet is something, or plant-focused diet is something you want to have it on a day-to-day life. And if you are looking for a non-plant source of food, then fish has shown to be a healthier option than the red meat options, especially beef, etc. So that's important. The other thing I'll tell people is stay away from liquid diet, which is drinking all the shakes and stuff. Our body is not designed to drink food. Our body is designed to chew food, because digestion starts in mouth and not in stomach. And you can't fool your body by getting all the nutrition in a short way. Food has to be a little difficult. It shouldn't be easy. When it becomes easy, it's called fast food or shake food, and that's where issues happen. So we need to give time for ourselves to respect our bodies and to eat well.
Great. Another question, what are some symptoms of prediabetes or diabetes? And with that, which type of doctor should you see to be screened for diabetes?
So most patients with pre-diabetes don't have any symptoms, and that's the reason screening should begin early. The patients with, and a lot of patients with early on part of diabetes, where the sugars are not that very high, they also don't have symptoms. Symptoms typically happen when people have very high blood sugar. I would say if they have blood sugars which are consistently more than 200 or 250, they might noticing that they're losing some weight they're feeling thirsty a lot, they're going to bathroom a lot, they just don't feel well. So those will be the typical symptoms. And obviously in severe cases, they will present with something we call diabetic ketoacidosis, where the sugars are north of 400 or 500. They are throwing up, they have abdominal pain, they're completely dehydrated. So they can present in variety of symptoms, no symptoms versus extreme symptoms. So if you have any of these symptoms, obviously you should get screened. But even if you don't, if you are an adult who is more than 35, who has any risk factors, then you should be screened. The screening typically is done almost always by primary care physicians. It's a simple blood test which they can do with your annual physical, or obviously if you have symptoms, they're going to screen you. You should not be waiting for an annual physical. You should get it done then sooner, which is an hemoglobin A1C. And most of the diabetes and prediabetes can be managed by primary care physicians. The patients who come to us as an endocrinologist are the ones who cannot be well controlled, despite of changes being made by primary care physician, or the patients themselves want to initiate a consultation with an endocrinologist.
Great. Another question is, can certain blood disorders such as anemia increase your A1C?
So blood disorders can make changes to A1C. Anemia actually can lower your A1C because hemoglobin A1C is based on the lifespan of RBC. In anemia, the lifespan of RBC goes down. So the A1C actually can be falsely low. So those are the patients where you would do a fasting glucose or a glucose tolerance, or sometimes another test called fructosamine, which can help us to understand what's going on. There are certain conditions like other conditions like chronic kidney disease or patients on dialysis, where the A1C can be falsely low as well. A1C very rarely is falsely high in something called polycythemia, where the hemoglobin is actually on the higher side. But it is usually the false A1C which is more prevalent compared to a falsely high A1C.
Great, thank you. And I think we just have 3 more questions. Somebody would like to know, do we have to have breakfast? What do you think of intermittent fasting?
So diet advice has been changing a lot, and I think you get every 2, 3, 4 years you get this new way of eating which is prescribed, and I think common sense always prevails. So what I tell my patients is to have a healthy breakfast. Breakfast should be one of your larger meals. The way I put it, when I see a patient, I'll say, have breakfast like a king, have lunch like a common person, have dinner like a poor person. So you want to have a breakfast at the start of the day, which is very a larger portion, not crazy large, but larger compared to your other meals. Have a medium-sized lunch, and have your smallest meal should be dinner. And the reason is our body is more active during the day and can process the food you're going to eat, and it needs that nutrition. But what happens is most of our people, including us, and we all have to work on that, is we get busy during the day, we don't get a chance to eat, we go home, we are really hungry, and then guess what? Our body is cooling off, the metabolism is slowing down, we're adding more fuel to the fire, it's going to overflow, and that's where the problem happens. So I do recommend eating 3 meals a day, and you can try something called intermittent fasting while eating 3 meals. Again, there are various ways, and various gurus will talk about different ways of doing intermittent fasting. And I would say most of them are not sustainable in long run. What I tell my patients, have breakfast around 7, 8, have lunch around 11 or 12, have dinner by 6 o'clock, and then put a tape on your mouth. You can have you can you can have water, but nothing other than that till next morning. So you can still eat 3 meals a day. You can give yourself 12 to 14 hours of fasting, and they do phenomenal on that. And that's something which is sustainable in long run as well.
Great, thank you. So Native Hawaiians historically think bigger people are wealthier, luckier, etc. Physically, they're higher in muscle mass as well. So how do we approach diabetes treatment to cultural perceptions?
That's a big question. That's a big question. So yes, every phenotype is different, and you have to every race is different. You have to understand where they're coming from. Now, what I tell my patients is that people are used to seeing you in a certain way. So if you are a certain size, and that's healthier for them, and that happens with Indian population as well, where I'm from, including my mom, right? Who tell me, oh, you lost a lot of weight. Are you healthy? And I tell them, because they're used to seeing you in a certain way. So when you shrink, they feel that something is wrong. But that's your new you. That's your healthier you. So it's important that you tell them that I am actually much healthier now. My pre-diabetes is reversed. My diabetes is reversed. I'm not on a medication. What you saw or what you perceive looked good to you, but that was not an healthy me. So that's something. It's a family conversation which you need to have, and I don't think I have a prescription for that. What to do? Yeah, I'm still fighting that with my family sometimes.
Great. And then our last question is, how does thyroid play a role in diabetes?
So there is no relationship between thyroid directly related to diabetes. You could have an indirect relationship where if you are hypothyroid or you have an underactive thyroid and you are gaining weight because of it, which causes obesity, which causes insulin resistance, and then you get pre-diabetes or diabetes, then obviously that's an indirect relationship. It's not that thyroid is causing diabetes, it's thyroid and underactive thyroid causing weight gain, which weight gain is causing pre-diabetes. So what I will tell my patients that if you have thyroid disease, then that should be fixed along with the lifestyle changes, because that's a quick fix. You fix your thyroid, you lose weight, you eat healthy, and guess what? You don't need a medication for pre-diabetes or diabetes because you can reverse that process.
Great. So I think that's everyone's questions. Thank you so much for everyone who submitted a question. And thank you so much, Dr. Patel, for the time and this great and meaningful topic for the AAPI community. So thank you to everyone for joining. We will end this first part of our presentation and move on to our team member presentation. Thank you, Dr. Patel.
Thank you. Thanks for having me.
Of course.